Hello, everybody, and welcome to the John Wayne Cancer Institute Be Inspired series webinar on the genetics of prostate, pancreatic, and colon cancers. It's our last JWCI webinar of the year, and in 2021, we look forward to offering more very informative programs, so please keep a lookout for invitations that will come your way over email. Before we get started, I want to give you some guidelines to make sure that you know how to ask questions of the physicians, and we really hope that you will ask those questions today. As you notice, everybody but the presenters are muted so that we're able to hear them well. In order to ask questions, you will need to type your questions into the chat box that's located on the bottom part of your screen. It looks like a thought bubble. And when you type the question in, I will then see it, or Dr. O'Day will see it, and the physicians will be asked that question. We'll take questions until the end of the talk. If we don't get to your question, I'll follow up in an email to you. And if you have a question after the webinar, please don't hesitate to email us. And again, I'll get those answers for you. We have a very interesting hour in front of us. We'll learn about the John Wayne Cancer Institute and St. John's Health Center's work in cancer treatment and research. We will hear about how genetics influences prostate, pancreatic, and colon cancers, both in getting cancer and in treating cancer. This program, like all of our cancer programs, is led by highly respected specialists in their field who collaborate closely with colleagues in other specialties to offer patients the best possible care. That's why we have on our panel today a medical oncologist, a surgical oncologist, and a geneticist. So you're going to be hearing from all ranges of specialty. You've received information on our speakers, so I'll let you read their full bio, and I'm very honored to introduce them today. Our moderator is Dr. Stephen O'Day, Executive Director of the John Wayne Cancer Institute and a medical oncologist. And he is, well, it's got his name on the screen under his picture, but he's the one with glasses. He can wave his hand there. Great. Dr. O'Day is a medical oncologist who is a preeminent melanoma specialist. And the John Wayne Cancer Institute has been a worldwide leader in the research in the immune system, and Dr. O'Day has led the seminal research project on immune oncology that revolutionized the treatment of melanoma worldwide. He and his team have been looking at how the work in melanoma translates to other solid tumors using the immune system to fight cancer. Our three presenters today are experts in their field that focus on prostate, pancreatic, colon cancers, and genetics. Our first presenter that I'll introduce is Dr. Ora Gordon. She's a nationally recognized expert in hereditary cancer and is the medical director of the Regional Center for Clinical Genetics and Genomics for Providence, Southern California. She is the clinical director of the recently established Providence St. Joseph Health Population Genomics Program and principal investigator for the system-wide Geno4ME study. Dr. Gordon is board certified in internal medicine and medical genetics. Her primary research interests include identification of hereditary cancer in the general population and individualizing risk for common disease. Passionate about the holistic approach to medicine, she's also completed a fellowship, that's 3 fellowships. Right, that's fantastic. In integrative medicine to expand options for primary prevention and nutritional research for high-risk patients. Dr. Gordon has co-authored an award-winning book for women facing genetic risk for breast and ovarian cancer called Positive Results, Making the Best Decisions When at High Risk for Breast and Ovarian Cancer. Our second presenter is Dr. Anton Bilchik. He is wearing the white coat. Dr. Bilchik. He is a surgical oncologist with a PhD in gastrointestinal physiology. He's an internationally recognized surgeon and scientist who has pioneered techniques to improve staging cancer and minimally invasive approaches to improving outcomes. Dr. Bilchik is trained and certified in advanced laparoscopic and robotic surgery. He is an investigator on international multi-center trials and has written over 220 publications and is considered one of the country's leading specialists in surgical oncology. We're also very proud to say that Dr. Bilchik is a John Wayne Cancer Institute Fellow, and he has been a great support to our fellowship program here. Our third presenter is Dr. Przemyslaw Twardowski, and he is wearing a suit and a tie, so the other person on the screen. Dr. Twardowski, or Dr. T, as we like to call him, is a medical oncologist and the director of clinical research in urology and urologic cancers at John Wayne Cancer Institute and the Cancer Center. Dr. T came to us from the City of Hope and is an expert in the management of genitourinary malignancies and prostate, bladder, and kidney cancer, and testicular cancers as well. Over the last 20 years, he was a principal investigator and contributor to multiple clinical trials that expanded treatment options for patients with cancers of the genitourinary tract. I am now going to hand over to Dr. O'Day and the panelists, and thank you very much for being here today.
Great, thank you. Can you hear me? Yes, great.
Yes.
Well, it's great to be here as the executive director of the John Wayne Cancer Institute. I mean, those introductions to our faculty are very impressive, and I'm so proud to help lead this institute. You know, in our previous seminars, we've been focusing on diseases specifically and the world-class teams we've put together. Today, we're actually one of the things that I'm most and very proud of in my tenure here is really the desire to bring not only medical oncologists and surgeons together around diseases, but to integrate medical genetics into everyday treatment of cancer. And it's really been an extraordinary decade of growth and of how genetics is being incorporated, not just hereditary genetic syndromes, which obviously Ora is world-class in, but also how the tumor genetics, so each cancer's genetics are separate from your maybe what we call germline or your hereditary susceptibility. And we're using both the hereditary cancer genetics, but also now we're really focusing on individual tumor genetics, which is impacting how we're actually treating patients with these cancers. And so maybe we'll start today with Ora giving us a general overview of how we think about the field that's evolved in the last years around both the germline and then maybe the tumor. And then we can talk, obviously Dr. Twardowski is an expert in GU malignancies, and prostate in particular has a hereditary and this tumor approach. And Dr. Bilchik's a world-class surgical oncologist in colon and pancreas. And so I think both of those diseases also are being impacted by both the germline or hereditary as well as tumor genetics. So why don't, or maybe just give us a little bit more of an overview. I may have simplified it too much, but drill down a little bit on, as a medical geneticist integrating into a cancer clinic, how your roles evolved and how you see these two areas sort of starting to come together and inform actually patient care on a very big level, I think.
Sure, Steve, and such a pleasure to be with everybody this afternoon. And, you know, I think you see in these frames, like the total continuum of care for a patient with cancer. As a, you know, self-proclaimed preventionist, I am the one who is at the crossroads between those who have cancer and managing them and those who are at risk for cancer who haven't gotten cancer yet. What has really evolved in the last couple of years and is transformative, probably in just the last 18 months, is the recognition of how much cancer, even those that seem to be just the one in the family or sporadic and not part of these super high risk, very exemplary cancer looking families, have an underlying genetic component that is inherited. And this has informed in two ways. One is in the identification of risk to that person and to their family, but as importantly, in many aspects has informed to specific treatments and to the development of targeted therapies that you know, take advantage of that underlying primary genetic change. And so we now see this threading together of both the, on every aspect of cancer care, looking at is there a hereditary risk, and does that inform treatment immediately? Is there a hereditary risk that informs for future decision-making, like what kind of surgical intervention might be best for that patient? So we have the surgical decision-making, the medical oncology decision-making, and then the future risk decision-making. And at the John Wayne, what we do is, for every patient, look forward to that. At that point in their diagnostic journey, where are they? And how do we put all those pieces of information together so that we can make the best treatment decisions immediately and long-term? Probably the most staggering change is how much we now have come to recognize the germline mutations or the hereditary mutations being a part of risk. And you'll hear over the course of this hour over and over again, sort of me hitting this 10% bar that we now recognize in prostate cancer, which has been sort of the cancer left behind for a long time related to recognizing the hereditary risk. At least 10% of prostate cancers, and even more when we start to look at some high-risk features, which Dr. T will talk about, have an underlying germline mutation. The reason why you got that cancer is because you were pre-programmed to be at risk. Pancreatic cancer, again, has transformed in just the last year and a half to say every person who has had pancreatic cancer needs germline testing. That's how significant it is, not only for treatment, but for recognition of risk. So let me take a break there.
So not too long ago, clinicians like Dr. Bilchik and Dr. T and I, we used to sort of, every once in a while, send you a patient and then sort of wash our hands of it and wait for your long, detailed, beautiful consults to know what to do. Just the sheer reality of what you've brought forward, unfortunately, as clinicians, we have to learn it at least well enough to know who to refer and who to not. And obviously, your team has expanded tremendously in our clinics, and you've been instrumental in educating both us senior clinicians and our fellows in what to look for. So with that background, I just think it's amazing the chemistry that we have now, the ability to get rapid information from your team, but also we're learning enough to be able to have intelligent conversations, which we really were not having so much in the very recent past. So we're going to go to some of the areas that Dr. Bilchik has expertise as well as Dr. T. But you brought up prostate cancer. And so Dr. T, now in the clinic, I mean, obviously you have a big prostate practice with Dr. Wilson, and you look at, you spend a lot of time in metastatic disease, obviously managing hormones and other treatments, but you also are at following men with early prostate cancer with surveillance and other things. So talk a little bit about how the genetics, both the germline as well as therapeutics, and who in prostate, we think of prostate cancer as we get older, an aging process, so certainly not hereditary. And it just like, so anyway, how is this impacting now? Because clearly genetics is front and center in prostate.
Yes, Steve, absolutely. It has changed tremendously. And I would echo that having, Ora and her team has, I think, accelerated perhaps our understanding here at the clinic level of some of these changes, having access to really world-class genetics program that we have. But I think, maybe just going back a few years ago, as you pointed out, it was rather rare that we were thinking about it for many reasons. One, that prostate cancer had this reputation of being less genetically driven, more aging related. Also, there was not that much known perhaps of what implications really these findings would have for therapy. We did know perhaps it may have an impact on better understanding of family circumstances and earlier prevention. But yes, that has really changed dramatically. So I would say that right now, majority of patients that I see with advanced prostate cancer, especially metastatic prostate cancer, would be referred for genetic testing to look for genetic predisposition for prostate cancer. Also, many patients with even non-metastatic disease what we would describe as high grade, so kind of higher aggressiveness based on microscopic evaluation. Many of perhaps patients on the line are familiar with the concept of Gleason scores, so these higher aggressiveness prostate cancer. And the reason for that is that we know that there is a substantial proportion of patients with these metastatic or aggressive prostate cancers, even without family history. I mean, family history is obviously still a factor, but even with no known family history, that may be harboring these genetic abnormalities in genes that are important, because if they're inheritable, they put at risk the family members potentially for these types of malignancies. But also recently we have had approval of certain drugs that are now applicable to treatment of prostate cancer in patients who have very specific mutations. An example would be the BRCA, BRCA mutation that is also linked to ovarian, breast, pancreatic cancer. But if it's present, if it's an underlying feature of advanced prostate cancer, we have now drugs called PARP inhibitors that particularly exploit the genetic variant and provide us with additional treatment options. So that really has been, I think, a game changer from my standpoint in terms of why I would want to know that in my patients really relatively early in the course of the treatment. So I have an opportunity to perhaps utilize these drugs through the course of treatment.
Great.
If I may talk about
Yes.
the initiative that we're looking to. So to that point, how do we identify people efficiently? How do we break down barriers, and not, especially if they're in the midst of getting treatment or if they're long-term survivors and they're coming back for kind of a check-in follow-up. So for about a year, more than a year, we've had these screeners in the urology clinic to say, okay, fill out this very short checklist when you're coming in for your appointment. And if anything is yes, then you meet an indication for hereditary testing, trying to really swiftly, identify folks by their own self-reporting of their, and what we know about their cancer, whether it was metastatic, whether it was high grade, and their family history. Check, check, check. If it's no for everything, that's a pretty good clear. Well, it's very labor intensive and we're cutting down a lot of trees. And so one of the things that we have worked on, and the first place we're going to launch this actually is in the mammography center, is utilizing a chat bot, so that when you get your invitation for your reminder for your appointment, you're also going to get a little link to fill out the equivalent of a very short questionnaire, and that will be a trigger. But the AI component of it is going to be then to provide education and pre-testing consent such that we can get testing done right away at that visit, at that time, even ahead of the visit, so that we have that information ahead and be able to integrate and incorporate that in. I really feel that it's so important for us to keep pushing out our ability to reach out to patients, as the more we test, the more we know that there are people who are at risk that we never in the years past would have ever considered for it. It's the same with pancreatic cancer and with colon cancer. We're really looking at how do we universalize both our assessment of patients and then also for those family members. So the start will be in our mammography center, and then I hope to have that be able to do the development, to be able to have that easily, readily morph to meet for the urology, because we have very high volume there, and then to start look at it from then on.
Great. Anton, so you're obviously involved clinically with the GI tract extensively, and I don't want to ignore colon, because as I've heard you mention, and there's an epidemic in early onset colon cancer, which is quite extraordinary in recent years, as well as obviously we've learned a lot in pancreas. So I know you focus on colon and pancreas. So how would you say these the overview of medical genetics, has that changed how you approach both early diagnosis and treatment of colon and pancreas, and then obviously how that may impact interactions with medical and other experts that get involved in the care? feel free to comment on either of those malignancies, wherever you think would be helpful.
Thanks, Steve, and thanks for the invitation to participate in this webinar. It's such an important topic. You know, surgeons typically have been involved in removing organs, and there's been a lot of interest placed on how organs are removed. Is it removed laparoscopically, robotically, or via big incision? And as we've learned more about the genetics of cancers such as colon cancer and pancreas cancer, we recognize as cancer surgeons how important it is to integrate genetics into our teaching, into our multidisciplinary tumor boards. As has been mentioned already, our multidisciplinary tumor boards always involve either Ora or someone from her group, because it really impacts what we do. Colon cancer, as Dr. Day mentioned, there's been a sudden explosion of young patients with colon cancer, and the natural assumption is that they're all carrying some germline mutation, because why would young people who don't smoke, don't drink, are not obese, don't have the usual risk factors, have colon cancer? And the immediate question we get from our patients is this genetic? And right now, the data would suggest that only 15% of those patients carry this germline mutation. The problem is and this is just an example of a patient that I saw last week, a 30-year-old woman who has Lynch syndrome, and Dr. Gordon, I'm sure will talk a little bit more about that in a bit, but Lynch syndrome is a genetic syndrome that can affect multiple different organs, and particularly the colon. And she has a very small colon cancer on the right side. Now, the standard approach to someone like that is to remove most of their colon and just preserve a very small segment of the colon, but that can be a life-changing operation. And so then the question is really, can you get by removing a smaller segment of colon? And if so, how do we work with Dr. Gordon and her team to really monitor this person, and what other organs are at risk for getting cancer as well? And this ties into other cancers such as renal cell cancer, uterine cancer. So it becomes a much bigger, complex subject. So colon in itself is something we're seeing a lot more of, that just literally every young patient should get a consultation with a genetic counselor, because it doesn't only impact them, but also their particular, their family as well. Pancreas cancer is a real problem, because we've made little progress in the treatment of patients with pancreas cancer. It's the fourth most common cause of deaths in this country. We've got more systemic chemotherapy drugs available, but the actual survival difference is still very small. So if there was a way to identify those people at risk for getting pancreas cancer, or identify families with pancreas cancer, then obviously we'd be in a much better position to monitor them, and then to identify cancers when they're early enough to be cured. So that's why one of the guidelines now, as Dr. Gordon mentioned, in pancreas cancer, is that every patient with pancreas cancer gets some form of genetic counseling, because it is such a devastating cancer. We really want to try and pick them up early. So this has become very much part of everything we do in GI cancers, and working as a team, as we do at the John Wayne with Dr. O'Day and our other oncologists and Dr. Gordon, is essential to provide optimal care in 2020, soon to be 2021.
So thanks, Anton. I mean, I would agree. I mean, we've made such success in so many solid tumors. Pancreas, once it metastasizes, or even if it's locally advanced, it's just been incredibly challenging. And some of that is how the cancer actually creates its own capsule and barrier to the immune system and to infusions, et cetera. So prevention and early detection is huge, but we've really struggled with early detection in ovarian and pancreas, two diseases that often present, unfortunately, too late. So knowing about hereditary risk obviously is huge. But, or do you want to? I think you and Dr. Hoon at our institute are involved with some early detection pancreas work that I think we've got to do better than we're currently doing. I'm very excited about that program. Maybe just introduce that a little bit.
Absolutely. So about a year ago, we launched a high-risk screening and research program, which is open to any of our patients in through the John Wayne, through St. John's, and actually regionally for any Providence patient. And there is a real benefit to having this be broadened in terms of both family engagement and access to care. So patients are invited to be part of this either as a high-risk screening program and research, or research alone. If they have a hereditary cancer risk gene, if they carry a change in BRCA or any one of a dozen genes that can increase their risk for pancreatic cancer, or if they come from very high-risk pancreatic cancer families, or if they have a pancreatic cyst, a particular lesion on their pancreas that's been picked up that may put them at higher risk. So there are these three branches, and we are providing education, we are doing discovery research, and monitoring the screening that they're having. So there is standard recommendations for high-risk screening for somebody who's at risk for pancreatic cancer through either an endoscopy looking with a special ultrasound to look at the pancreas, or a specialized MRI. Dr. Hoon and I, and the part of this program, are looking in this discovery. The goal being a blood test that could be an early detection marker, looking at unique features of DNA that's circulating around in your blood that may be little fragments of cancer that are turned on and off in a way that provides a signature for pancreatic cancer, such that we could then say, this person is particularly at risk and we need to do something really look at the pancreas. And if we find an early cancer, refer them to Dr. Bilchik to consider taking out part or all of their pancreas. And so in these national consortiums, we know that imaging does find cancer earlier. And so that will help move the dial back. Maybe the therapeutics will become more, have higher efficacy in those earlier stages. We're really looking at this on a many pronged way. Can people get the imaging? What is happening from an outcome standpoint? Can we change our therapeutics? And so anybody who's on the call who has a hereditary cancer gene that puts them at any elevated risk for pancreatic cancer, or has a family history of pancreatic cancer, or who has had incidentally found something, a particular kind of cyst or change in their pancreas, is invited to participate. This is philanthropically covered, so not the imaging or any downstream testing, but the research, the education, and all of the surveillance that we're doing sort of within the clinic.
Great, thanks, Ora. Now, Anton, you know, with breast and ovary and colon, I mean, essentially at very, very high risk patients, you can essentially remove the organs completely and abrogate that risk. Not 100%, but very close. The pancreas obviously is potentially a different organ. Are there ways of reducing pancreatic risk prophylactically, surgically, or is that just a whimsical idea? What's the role of the pancreas?
Yeah, so the pancreas has very important roles in the body in terms of releasing enzymes that help absorb food, and releasing hormones, insulin, glucose that help maintain normal glucose levels. Now, if someone has a normal pancreas, you can actually remove up to 75–80% of the pancreas without any pancreatic abnormality afterwards. So just about every person that is about to have a pancreas operation will ask, am I going to become diabetic? And the answer is, if you're not diabetic now and your pancreas is healthy, you will not be diabetic afterwards. Now, if you are borderline diabetic, then taking out a small part of the pancreas can certainly push you over the edge to become diabetic. Now, just getting back to what was discussed before, the pancreas is a very difficult organ to operate on, in the sense that If it's in the head of the pancreas, it's a very involved operation called a Whipple procedure, which is a complex lung operation to remove the tumor. If it's in the tail of the pancreas or the body of the pancreas, it's certainly simpler. But the fundamental issue with pancreas cancers, getting back to what Dr. Gordon was saying, is that 90% of patients, by the time they present with symptoms, the cancer has already spread, and the chance for cure has gone. So if there was any way that one could identify those people at risk early on, then a curative operation can be done, and can be done safely, because the smaller the tumor, the easier the operation and the safer the operation, and the greater chance there is for cure. Now, the standard way of screening is CAT scan, MRI, and endoscopic ultrasound, but this has all been taken to a whole nother level of blood tests, which Dr. Gordon referred to, and perhaps even some sampling of the pancreas endoscopically, looking for some high-risk features.
Great. So I think we're going to go to some questions shortly. I think I want to just follow up with Dr. T on one thing. We don't want, obviously prostate's been your focus, but I know you spend a lot of time thinking about bladder and kidney cancer. Can tell us about how those cancers might be involved with either genetic predisposition syndromes, or how therapies might be changed by interrogation of the tumor, so to speak, genetically?
So that's a very good question. I would say, we pretty much every cancer now has some known potential genetic inheritable component, although obviously to various degrees, as we pointed out today. In some cases, it may be very rare that we can identify certain genes. So in kidney cancer, right now, it really has to do more with prevention and family surveillance. Really, we don't have any specific, or very, very rarely, it's really incredibly rarely that we would find some hereditary specific gene mutation that would have implications for therapy yet. But still, in the clinic, when I see patients with kidney cancer, for example, at the younger age, so the usual kind of suspicious circumstances for some hereditary component, age of, for example, kidney cancer, 45 or less, would be unusual to have what we would call standard kind of bad luck kidney cancer. Or if the kidney cancer is on both sides, in both kidneys at the same time, or multiple places in the kidneys, then there are certain specific syndromes that are linking kidney cancer with other malignancies, including actually pancreatic type of malignancies or brain tumors. So if you see the conglomeration or congregation of these unusual circumstances, you would definitely start thinking about it and referring patient for genetic testing, mostly, as I said, to potentially identify it and then perhaps screen family members for that gene with much more intensive surveillance, because that can be very helpful to detect kidney cancers, but no real therapy implications. In bladder cancer, the one circumstance that perhaps would render itself to specific therapy in the context of some genetic abnormalities would be that what we mentioned today is that Lynch syndrome, which is a pattern of certain DNA repair abnormalities or alterations that can be associated with cancers of the urinary tract, colon, uterus. But from my perspective, certainly urinary tract would play a role. So again, if I see somebody at the younger age, that would raise some suspicion. And the younger age would be, again, 40s, no smoking history. Usually standard, quote unquote, urothelial bladder cancer is linked to smoking. So if I don't have any other risk factors, younger age, maybe family history of linked malignancies like colon, uterus, that would raise some red flags. And that does have potential treatment implications because those cancers may respond a little bit better to immune therapy. So, but I would say that overall, perhaps these tumor types that I see, bladder, kidney, are maybe slightly less investigated from the genetic standpoint than prostate cancer these days. I think that has maybe a little bit more, I think, maybe just because of the prevalence, numbers of cases that we see, but also, again, these new drugs that we have make it, I think, very appealing to look for these things.
So this is why I think the teamwork of involving multiple disciplines, I mean, just keeping track of the new therapies is extraordinarily challenging, and then all the genetics on top of it. So thanks. So I have a couple questions for Ora, then we'll go. So this just came up to me. I don't know the answer, but people with the more common environmentally induced cancer risk factors like smoking, drinking, sunlight, obesity, are they like independent of your hereditary risks? And if you are, let's say you have a genetic predisposition through a gene, let's say lung cancer, you take an example, if you had that hereditary predisposition, albeit probably a small subgroup of patients, does stopping smoking in any way, lower your risk, or are they sort of separate mitigating factors? I don't actually know the answer to that.
So it's a really good question, and I think it comes up a lot. So it comes up a lot in folks who are at very high risk in terms of feeling like, what can they do to have some control over their risk in their future, and can they mitigate that risk? Can you eat your way out of a BRCA related risk? Probably not, but we do actually have a tremendous amount of evidence to modifiers. So you can carry a hereditary susceptibility and go your entire life without cancer. And then within the same family, somebody who has that same genetic change may present at 30. So these modifiers is really where we're looking at in this this next phase. We're doing a pretty good job of finding the single gene changes. And now we're trying to really say, well, what about the folks who don't? So what about that, 40-year-old with cancer who we don't find a germline, we don't find a hereditary single gene? How do we explain their vulnerability to cancer? And then how do we explain what environmental responses are? So there's something that's beyond the scope of our talk today, but it's called your polygenic risk. Looking at a whole bunch of tiny variations within your genome, within your genetic variation, and where are you on this bell curve? Are you stacked high towards cancer risk, colon cancer? So we have this actually commercially available for breast cancer, colon cancer, and prostate cancer currently, and we're looking at it in heart disease and in every kind of common disease of adulthood. Or are you all the way at the tail of the protected end, such that maybe ultimately your screening, you wouldn't need a mammogram every year, that you're probably not in that risk group that would need that, or that your colonoscopy intervals can really be at 10 years. There was there's been some really interesting data on environmental risk and your polygenic risk. So that if you have a really high polygenic risk and an environmental risk, that pushes you into you're probably going to get cancer. But you can mitigate that polygenic risk through behavioral lifestyle modification, so that you could have a high polygenic risk, but not smoke and have an optimal anti-inflammatory diet and exercise regularly, and pull that risk down into the normal or subnormal population. So this is a tremendous opportunity, I think, for both personal engagement and really trying to understand that it's, that the bad luck thing, that we have some ability to get our arms around the bad luck and change that into a preventive.
But now I'm really discouraged. I still have to exercise and not smoke or drink and be very mindful whether I have a hereditary risk. Thanks a lot.
But yeah, I'm not going to tell you about the smoking stuff where basically, if you're the George Burns, if you are so protected, if you're genomic protection, you can smoke every day to 99 and not get cancer.
Can't you tell us that? We don't have to exercise. We can
even
eat
if I could, I wouldn't. See, I would hide that. I would withhold that information from you to say
behind the veil of ignorance. All right. So I have a couple other questions, but I'm going to respond to some of the chats from Marion Craver. My husband, let's see. My husband's father had prostate cancer, and both of his grandmothers died from colon cancer. How can he be tested for genes of these cancers? So what's the, I guess, relationship between prostate and colon, if any?
T, you want to take that?
Well, so there is some, increased risk. I think I may defer to Ora, but certainly, it's not one of those real strong red flags that I see here. There's certainly slightly increased risk of prostate cancer in this Lynch syndrome that would link it to perhaps colon cancer here. But again, I think that would require a little bit more expertise and detailed assessment because, prostate cancer is so common. So if your husband's father had prostate cancer at the old age, and then there was some colon cancer there on that side, I'm not quite sure if that raises to the level of, testing. But I would say that perhaps Ora can comment more on it. There is certainly possible genetic link there somewhere, but
I don't think we need to get into specifics for individual questions, but it's just in more general. I think that's really helpful. So Ora, there's a lot of cancer genes. We used to have a handful, BRCA, and so, but now it seems like you're doing 300, 400 genes. What a nightmare for us to look at these things, and some of them you think are of unknown significance. My coronary squeeze every time I look at some of these. How do you talk to patients about what's, obviously you're gaining a lot of data and information, and you're being very transparent in these reports where we clearly have known high associations and others that are under investigation. You update these, which is really important over time, and give feedback to people. But how many genes are you testing for now, whether you're coming in with your initial diagnosis of breast or pancreas? Is it the same panel for everybody, or what? How do you approach this?
Yeah, and so there isn't a one size fits all. We are in the 80 plus number of genes that we can test for sort of every known, if the patient wants to, and if it makes sense medically, you could test for every known hereditary cancer susceptibility gene with one test. So there are multiple platforms that allow for 80 to 90 genes being tested at a time. With any test, right, what is your false positive, or what is your predictive value? How relevant is that? And do you pick a panel that's the biggest panel because it's pick me, I'm the biggest panel, or do you hone in on the genes that are relevant to that person's personal and family history? And so it's a little bit of a philosophical, and there's a lot of medical information around it. And everybody, we sort of talk through that with everybody as to what's the right level of testing for them. I want to take a moment just to kind of say part of what Dr. T was struggling with was, does this person meet criteria? Is there enough? Yes, colon and prostate go together in a pattern, but now you have this individual who's fine and maybe he's in his 50s, 60s, and he hasn't had cancer. How do we know whether they're at risk or not? So part of this initiative that Jean had talked about in the beginning is this Genome for Me study that we're going to be launching at the start of next year, and it's going to be available to all Providence patients. And I'm really happy to say that we're one of the first sites that we're going to launch it in clinically is the Santa Monica Family Medicine Family Practice here at St. John's, because they're very engaged and we have such a broad variety of patients. And it's offering hereditary, so it's a whole genome study that will offer back return of results for all clinically actionable. So we have national guidelines to say this is a cancer that we know what to do with. So that's called the NCCN, and specific cardiovascular risk, and a very limited risk for how do you manage, what is your response to certain very common drugs. So that's what's going to be coming back. I'm going to do it as an educational platform to be able to say, let's take it out to the population and try to get information about how many are we missing. We keep learning that we're missing our guidelines, as good as they are and as more generous as they become, to make the age requirements less restrictive, to make the family history requirements less specific, to be, you know, more targeted about the certain tumor types, that we're still missing plenty of people who have hereditary risk. So this approach, this population-based approach, the idea is to say, all comers, you've had a personal history of cancer, you have cardiomyopathy, you have nothing, you have some family history. Let's get all that information for everybody and then try to turn that back around to making these recommendations clinically. So I think that within 2 years, we're going to be testing every single epithelial tumor, every single of a certain kind of cancer will all have germline testing. I think that will become the new standard of care.
So I'm going to go through some, we're getting inundated with questions, which is wonderful. It means everyone's engaged. So I'm going to try to go through a few questions and maybe panelists try to give me your most succinct response. The first is to Dr. Gordon. Is there any new data on genetics of somebody who has both a chondrosarcoma and a leiomyosarcoma? So two different sarcomas.
There's a condition called Li-Fraumeni, P53. So that would be what I would test for. That would be a very specific, and there are some sarcoma genes. So yes, that person should have genetic testing.
I have a close affiliation with Li-Fraumeni because I trained with Dr. Lee at Dana-Farber back in the 80s. I'm dating myself, but he described that initial syndrome with P53. So yes, leukemias, adrenal, help me out here. Brain sarcomas,
right?
About a number of cancers.
Right.
Okay. Let's see. Sorry, I had one for Anton, but if one has, this is for T, I think. If one had a rapidly growing prostate, what determines if it's cancer or benign?
So, in a rapidly growing prostate, I assume somebody who is having more and more difficulty urinating and prostate blocking. I mean, most of the time happens to actually be benign, but it's worthwhile checking it out. And the tests that we look for are blood tests called PSA, digital rectal examination, and then we are increasingly using MRI imaging to look at the prostate in the kind of questionable circumstance and to make sure that it looks fine, that there are no cancer suspicious spots. But ultimately, we may require biopsy, needle biopsy, to rule that out.
Okay, we're now there are so many questions here, and I know afterwards we want to be able to address them. You'll be able to, we'll have a record of this, and Jean and the foundation staff will get to us. But Anton, what are the symptoms of pancreatic cancer, and when are they experienced by those who have it? What is the percentage of pancreatic patients that actually were made aware of symptoms prior to being diagnosed and it being too late?
So one of the issues with pancreas cancer is that the symptoms can be very vague, very, very non-specific. Vague abdominal pain, weight loss, bloating, jaundice. And again, it's just a very non-specific presentation. And by the time most people present with these kinds of symptoms, often the cancer, not always, but often the cancer has already spread. So we're picking up more and more pancreas cancers, not because we're looking for pancreas cancers, but because someone's getting a scan for some other reason. So for example, a scan of the liver or a scan of the gallbladder, and then suddenly something is seen in the pancreas, and then it gets worked up. And so we're seeing more and more pancreas cysts, small pancreas cancers because of that. A lot of the reason that pancreas cancer symptoms can be very non-specific is that the pancreas itself is kind of centered in the middle of the abdomen, and it has a very dense blood supply. There's a rich lymph node supply and nerve supply. So the cancer tends to spread very quickly along those nerves, along those blood vessels, and only cause symptoms by the time they've had a chance to really spread to areas like the nerves around the back, for example, the celiac plexus nerves, before they cause back pain. So again, I think anyone that has unexplained weight loss, bloating, symptoms out of the ordinary should go to their doctor, and certainly something in the pancreas should be considered.
Yeah, that's a great answer. And I think, ovarian and pancreas are very similar in that regard. So these non-specific abdominal, could be mild, but bloating or just you're not right. Okay, Ora, this is, so if your grandfather on your mother's side died from colon cancer, are you creating a pedigree here? And then your mother died at 64 years old from a cancer of unknown origin, maybe biliary. And then you have, plus 2 other of her sisters had cancer, breast and lung. How much worse would I, being a woman, being 39 years old, be? So it looks like so there's colon, biliary, breast,
so
and lung.
I'm going to leave rather than to, so this is exactly the kind of thing where, you know, we get a full family tree or a pedigree, and then we look at what might be reasonable genes and kind of talk through with that person. And you mentioned that they're 39, maybe adding this polygenic risk if there's no hereditary. One thing I would say, if there is cancer in the family and that person is alive, and you as the unaffected person are worried, it is always best to test somebody with cancer or with the condition, because that gives us the most information to inform to everybody else. So especially in pancreatic cancers, or if somebody has an advanced cancer, the opportunity, you want to try to get that genetic testing while you can, when that person is still with you, so that it can inform for everybody within the family in the most clear way. Otherwise, when you have a negative test, we have to say, well, are you negative because you're true negative and you're off the hook because your parent had a BRCA mutation? Or is it something that we just don't know how to identify yet and you might still be at risk?
Great. Jean, we've got about 7 minutes. There's a few more questions here, but I could also, I want to make sure you have an opportunity to say a few things if you'd like, and I could also make some closing comments too. But
great. I think let's go for a few more minutes. There's a lot of questions.
Okay. There's a follow-up, I think, on that chondrosarcoma question. If it was in the amygdala, so it sounds like it was of the brain, does that make, I presume they're asking whether leaf Formanes, given that there's brain also, make it more likely?
You can't have a chondrosarcoma in the amygdala. You don't have.
Yeah, okay, it seemed a little, that's what, I may have the question wrong.
But that person should reach out and we can.
Yeah, okay. Let's see. So T, for patients who have been considered successfully treated for prostate cancer, should they seek genetic testing? And you addressed this maybe, but just follow up to guide elevated monitoring for related cancer risks.
I think that's a very good question. You know, I think potentially yes. You know, other than perhaps, you know, if you have no family history whatsoever and the cancer was kind of bread and butter, low grade, and there's no other red flags, I would say probably not at this point. On the other hand, if this was a treated cancer that was, you know, relatively higher grade, Gleason grade, that we would have tested now routinely, or also on top of that, if there's any family history of related cancers, I would say yes. So in many patients, the answer I think would be yes to that.
Yeah.
Great.
It wasn't that before. Yeah, that's
Right. I mean, these are very sophisticated questions. Okay, so for Anton and Ora, I think you both can address, how fast do pancreatic cancers grow, and can an annual MRI be enough to catch it early enough? And what is the role of MRCP? So how good are these at really making a difference, even when we know somebody's at higher risk?
So I'll start with the second part of that question. So MRI is becoming more and more sensitive for picking up even the smallest pancreatic lesions. We used to use CAT scan primarily for diagnosing tumors in the pancreas, but now MRI is slowly taking over in many big academic centers as the test that is more accurate at picking up these very, very small lesions. And an MRCP is it's an MRI of the bile ducts, the liver, and the pancreas. I think the key in ordering an MRI for the pancreas, we're always very careful to order what is called an MRI pancreas protocol, because we want to not only look at the very small lesions in the pancreas, but we also want to see the relationship of these lesions to surrounding blood vessels, because that really determines how to sequence treatment, whether to consider surgery first, chemotherapy first, radiation. But MRI is a very accurate way. As far as annual testing and how quickly pancreas cancers grow, it depends. I mean, some pancreas cancers grow very, very quickly and have a very rapid doubling time, meaning that they just double in size within weeks. Others grow very slowly. So very difficult to tell. A lot of patients ask when they diagnose with pancreas cancer, how long have I had this for? Usually by the time you pick it up, it's been there for quite a while, because they start off very small as just cancer cells before they actually get to the point that they're picked up by imaging.
Okay, I think, yeah, you did. There's one more, and then I think thank you. That was a great answer. So there's another question that I think I'd like to address regarding immunotherapy in people with colon cancer, but others. I think there's obviously a tremendous interest in cancers that have very environmental sort of predisposition, like ultraviolet light for the skin cancers, particularly melanoma, but also squamous cells of the skin and others, alcohol and tobacco related cancers. These are all, they create such disturbance in the DNA that new, what we call neoantigens or tumor related proteins get put on the surface of the cancer, which is very visible to the immune system. So a lot of the major progress in immune treatments of advanced cancer is related to this. There's also a whole now an understanding that not only are there environmental toxins, but predispositions to what we call DNA repair. And the obvious genes around this were the classic BRCA genes, but there's specific genes that inhibit where your DNA repair is not as good as it should be, predisposing to cancer. But it now looks like there's clusters of genes that may not be individually as powerful as BRCA, but speak to how a cancer cell repairs itself. And when it's not working well, meaning the repair, it's putting a lot of surface proteins that are making it more visible. So, for example, it's a long answer to colon cancer. There's a subtype of colon cancer that has a DNA repair abnormality called microsatellite high, meaning those patients are incredibly susceptible in a good way to immune treatments. But even in patients that don't have that susceptibility, we're finding ways to approach what we call colder tumors that need help with immune. So more to come on that, but we're definitely getting the low-hanging fruit with environmental predispositions to cancer with immunotherapy, but also around DNA repair. Or do you want to just add anything to the DNA story?
Well, the only thing that I would say is that, we screen every colon cancer for this particular change in terms of the mismatch repair deficiency. It's done in pathology. Nobody has to ask for it. It doesn't get ordered. Every single colon cancer and every single uterine cancer that's operated on at St. John's gets this screening test to see whether or not this could be a mismatch repair abnormality. I don't know whether Dr. Bilchik's 30-year-old was picked up that way or whether it's because she was 30 that it became called to attention that they found Lynch syndrome. So this becomes really important both for understanding that this could be hereditary as well as identifying that this may be somebody who is best treated either with or without certain chemotherapies, because we have, depending on the stage, that same sensitivity.
Absolutely. So that's a whole new area. So I think we're up for time, but I just want to say, as the executive director of the Cancer Center, and what a great group of faculty to bring together. I think what this really illustrates, hopefully to all of you listening, is the way that John Wayne is not only bringing disease teams together across disciplines, meaning melanoma, brain cancers, colon cancer, but we're also integrating medical genetics and psychosocial care, two really, really important sort of glue that holds the cancer team together. And you saw today that how medical genetics is not just sort of a dessert to the meal. It's really a main course right now, because it's integral to how we as clinicians make decisions, not only about protecting families that are high risk and individual patients, but our treatment decisions are actually being impacted. And we can't possibly keep up with that without the help of people like Ora and her discipline and her disease. She's also does complementary medicine and sorry, what the
Integrative.
The what?
The integrative medicine?
Integrated, sorry, integrated medicine. And that's a whole different topic, that integrated medicine and psychosocial, how we've already integrated that into the mental health and the sort of comprehensive integrated approach to cancer treatment. So really proud of this team and today's discussion. I hope that really helped stimulate interest and questions, and we're happy to answer questions further through the foundation. And we look forward to looking for our future webinars.
Well, thank you very much, Dr. O'Day, for that. And thank you, all of you, Dr. Gordon, Dr. Bilchik, Dr. Twardowski. Really interesting and incredibly informative webinar today. We've all learned a lot, so thanks very much. And as this is the last webinar of the year, I would humbly like to ask you to consider John Wayne Cancer Institute and St. John's Health Center in your end-of-year giving. Your support allows us to provide research and clinical trials that are prolonging and saving lives for our patients that we've heard about today. And the work is incredible, and we really can't do it without your support. So thank you for considering that for us. If you're interested in receiving invitations for future webinars, please send us an email and we will put you on the list. We've sent you a number of emails with our links to this webinar, so just respond back to that, and then we'll be able to put you on the list for future invitations. And thank you all for being with us today. Have a wonderful, safe holiday and a happy and a safe New Year. Safe being the operative word at this point. Thank you very much for joining us.
Thanks, everyone.
Everybody.
Thank you. Bye-bye. Thanks a lot.